Hi, I'm Jerry Tan, the Acne Doc, and I'm here today to give you some very clear, useful information about this condition that looks a lot like acne in some patients but isn't. It's called rosacea. So I'm going to break it down into how we help diagnose, manage, and then eventually control the features of rosacea. So let's get started. The first issue with rosacea is that it's not simply one condition. In fact, rosacea is a number of different features that all come together. And when those features all come together, that's the name of the condition, rosacea. What do we see? Well, we first start with central facial redness of the skin across the cheeks, nose, and sometimes affects also the forehead and chin. That persistent redness is called persistent centrofacial erythema. The second feature that is also diagnostic is skin thickening, typically affecting the nose. That's a condition called rhinophyma. Rhinophyma is very characteristic for rosacea. Very few other conditions look like that. Now then there are other features that are characteristic of rosacea, but you need two of them to be diagnostic of the condition. For example, the pimples, we call them papules and pustules of rosacea, in the absence of comedones, are more characteristic of rosacea or folliculitis. If you also have periodic flushing or redness, that's also characteristic of rosacea. Another feature are prominent blood vessels at the cheeks, around the nose, the forehead, particularly in the absence of significant amounts of sun exposure that can also lead to prominent blood vessel marks. In the absence of that, then that might also be a feature of rosacea. And finally is eye involvement. Dry eyes, easily irritated eyes, recurrent styes, those may all be also features of rosacea. We call that ocular rosacea. So you can see when we put all of this group of spectrum of conditions together, there's not one thing that is rosacea. There are multiple presenting features of rosacea. Now, when we manage rosacea, we have to understand how that patient presents. And if that patient presents primarily with the fixed redness, or the redness and the pimples, or the redness, pimples, and eye irritation, our approach differs depending on each of those individual features that are presenting. And that's called a phenotype, the features presenting clinically in the individual patient. General gentle skincare, sun protection, and trigger avoidance. And for example, some people are also triggered not just by sun, but also by spicy foods, also by alcohol. So all of those are important to recognize and to try to minimize whenever possible. For the background redness, whether it's mild, moderate, or severe, it depends completely on the patient whether they wish it to be treated or not. For very mild patients, sometimes treatment is not necessary unless the patient is bothered. If it's more moderate, it's severe, oftentimes patients will request treatment because the redness makes them look like they're embarrassed all the time, or angry all the time, or that they've been drinking when they haven't. So for any of those aspects, redness can be treated, and it can be started with medications that you apply directly on the skin called topical alpha adrenergics. Those medications are topical oxymetazoline or topical brimonidine. Those particular medications can be applied. They work temporarily over a course of 6 to 8 hours to reduce the redness, and then the redness progressively recurs. And it helps about 75% of patients. There's a small group of patients that gets worse with these treatments, and if you're one of those patients, you should stop treatment. The next option for patients who right off the bat have severe forms of redness, often the use of beta blockers off-label can be very helpful. These are beta blockers that are typically used for high blood pressure, but in the context of rosacea can be very helpful to reduce the redness. And then there are also energy-based devices like the pulse light devices, blood vessel laser devices. Those can be extremely helpful for long-term improvement rather than the temporary improvement when medications are used on and off. For the transient redness, the transient flushing and blushing that some people get, if it's very mild, perhaps again, no treatment required. If it's more bothersome, it's moderate or severe, certainly some of the other options may be considered, including beta blockers, including some of the energy-based devices like pulse light or lasers. And oftentimes we see very nice reduction in the background redness when we use these energy-based devices. And periodically, after a session of 3 to 4 treatments, 1 month apart, many of these patients can be controlled for months to a prolonged period at a time. And then about once a year, once every 2 years, they come in for touch-ups to help them maintain their control or keep control. The pimples of rosacea can look very much like the pimples of acne, except that 2 things are different. One is that the pimples of rosacea tend to be not associated with comedones. Comedones are those little blackheads or whiteheads that we see very characteristically in acne. The second part is that the papules or pimples of rosacea don't tend to leave scars, whereas the ones with acne do tend to. So with papules and pustules of rosacea, we can always start with some of the lotions and creams, topical ivermectin, metronidazole, azelaic acid. For more moderate and severe forms, there is also topical minocycline and topical encapsulated benzoyl peroxide. Over a course of 8 to 12 weeks, if there's inadequate improvement despite repeated ongoing use of these medications, if that happens, you're not seeing enough improvement, and sometimes we'll add one of these other medications to it to form a combination to try to give you more improvement. And oftentimes, if it's much more severe right off the bat, we can also start not just with topicals, but also the addition of some of the oral medication like doxycycline or minocycline. Erythromycin sometimes is used for patients who are allergic or intolerant of the cyclins. If those are inadequate, the use of low-dose oral isotretinoin, which is also used in acne, by the way, but in low doses, it can be extremely helpful for patients with just stubborn, difficult to control rosacea pimples. So in patients with rosacea, we have to look at the presenting features, determine which of those features bothers the patient, and then target them with a very specific treatment. And we can do that with patients with multiple different presentations and different features, and give them a chance to voice what it is that bothers them so we can target those features specifically with treatments. And these treatments can work extremely well, whether we're using topicals or topicals with oral medication for the papules and pustules of rosacea. And then, of course, we also have considerations of blood vessel marks, and blood vessel marks are very effectively treated these days with the lasers and the pulse light devices. For the skin thickening, FIMA, if it's inflamed, we generally start with the anti-inflammatory medications like some of the topical medications you've already heard about. We can also add in the use of doxycycline or low-dose oral isotretinoin. Once the inflammation subsides, if the thickening is bothersome to the patient, then surgical approaches can be used to trim down that excess tissue and resculpt those affected areas, such as the nose. Ocular rosacea, the structures around the eyes you can think of as the cutaneous structures around the eyes, like the lids, the anterior chamber, which is the front of the eye, the conjunctiva, for example. And how these can be affected in rosacea is the following. When there's ongoing inflammation, when there's demodex, it can plug up some of the oil and tear film follicles that are important in lubricating the surface of the eye. That ongoing blockage can lead to styes and pimples around the lid margin alongside the lids themselves. And that abnormal tear film formation can lead to dry eyes, which then causes a gritty sensation, a dry sensation, and in very severe cases can lead to such dryness that it causes ulceration of the cornea. And a patient presenting with pain or rapid changes in vision with rosacea needs to see an ophthalmologist as soon as possible on an emergency basis. However, thankfully, in the majority of patients, we can control and improve some of the lid margin effects and reduce the problem with dry eyes by the use of artificial tears. Lid margin involvement, we can often get improvement with some of the topical medications we talked about, gently applied to the lid margin. And the use of some of the oral anti-inflammatories can also be extremely helpful. So there are many ways to help with ocular rosacea. So in summary, the thing about rosacea is patients will present with individual specific features of rosacea, and each of those features have very directed treatments. So this is an evidence-based framework to manage and improve rosacea based on the features you have and what you're presenting with and what bothers you. I hope this helps, and if you have any questions or comments, feel free to leave in the comment boxes below. And remember, all of this is for education and information. None of this is meant to be specific medical advice to you. If you do have rosacea, please seek attention from your medical care professional. Thank you.